Okay, so we're recording now, I believe. Let's see. Yep. Okay. So we're going to go over two things tonight. We're going to go over asthma, and we're going to go over abdominal emergencies. And then we'll, I printed out the test and saved it as a PDF, so we can go over the test questions just to see if I covered everything that needed to be covered and stuff like that. And then we'll call it a night. You guys can do the test when you have a second. So asthma basically is an issue with the immune system, specifically affecting the lower airways, where the lower airways become very hypersensitive to certain stimuli. So this, those are called triggers when you have an asthmatic. So there's multiple things that could be triggers. You've heard of, exercise-induced asthma. I mean, dust, pollen, stress, cold weather, warm weather. So there's multiple things that could be triggers to asthmatics. Not every asthmatic has the same trigger. Some of them have one trigger, some of them have multiple triggers. But something happens, that just kind of like anaphylaxis, where they're exposed to something and they have a response by their immune system causing certain problems. The difference between anaphylaxis and asthma, that anaphylaxis is a systemic issue where it's affecting multiple body systems. In asthma, it's specifically only affecting the bronchioles, which are the lower airways in the lungs leading to the alveoli. So, that's kind of how it's a little different. But, we know that patients die, from asthma. We know that patients die from anaphylaxis. So it's not that asthma is a benign disease. Most asthmatics nowadays, with treatment have very good control, but there's still, there's still asthma deaths, not as frequent as years ago, but there's definitely still asthma deaths. So basically what happens is that your bronchioles are lined with smooth muscle, right? So we have different types of muscles in our body. We have skeletal muscle, right? We have smooth muscle, and we have cardiac muscle. So cardiac muscle is only found in our heart. And the thing that's special about cardiac muscle is has the ability to initiate its own impulse. So it doesn't need the brain to react to it, okay, or a brain to tell it to do something. Skeletal muscle, obviously, we have throughout our skeleton, right? That's what allows us to move, lift things, and stuff like that. And smooth muscle is found in our airway, okay? It's found in our intestinal tract, okay? It's found in your urinary tract. Blood vessels have smooth muscle in them. So, smooth muscle typically requires the brain to react to a stimuli and tell it to do something. So like with the, with the lungs, if you're breathing, need to bring in more oxygen, then the smooth muscles in your lungs would relax to increase the size of the airway. If your blood pressure is too high, your blood vessels will relax. If your blood pressure is too low, they'll constrict. So if you're eating food and they sense pressure, your esophagus will start squeezing the food and moving it down, called peristalsis. So, so in this situation, the smooth muscle is over responding to something, right? So like if you're exercising, you're an asthmatic and that's your trigger, that stress of the exercise is causing your bronchioles, instead of to dilate to let more air in like it should, it's causing it to constrict, okay? So that's the first thing that happens. So obviously if the muscles of the bronchioles constrict, the tubes themselves get narrower. The walls of those tubes get thick. So that also decreases the diameter, the inside of the airway. And then the last thing is there's increased mucus production. So mucus is actually a good substance. We need mucus. Mucus lines our entire airway, from our nose all the way down into our bronchioles, right? And mucus is basically a substance designed to trap pollutants and not allow it to get down into the alveoli. So we have little hairs called cilia that line our entire airway, and they are actually waving towards your nose. So from the bottom of your lowest parts of your airway, all those cilia are waving upwards constantly, okay, up to your nose, right up to your mouth, and it's driving that mucus backwards, out your mouth, and you actually swallow most of the mucus you produce, okay, which is sometimes, if you've seen, if you really had a really, really bad nasal congestion, happens more in kids, but if you have a lot of excess mucus production, sometimes because you're getting so much mucus in your stomach, you get nauseous and you may vomit. It's kind of a streaky vomit that it's usually kids, but once they vomit, they usually feel much better because they've kind of got it out of their system. So mucus definitely has a role in it, and we're going to see that one of the things that can happen with the way we tend to treat patients with giving them oxygen straight out of a tank without running it through a humidifier is that we could cause something called mucus plugging, right? So if mucus is a sticky substance, you don't want it to get more sticky and start to plug up the airways, because then the patient can run into, major issues by occluding the different bronchioles. So this would be an example of what mucus plugging is in a dead person, right? So this is a bronchiole that was dissected out, right? So it's open so we could see it sided. And this whitish material in here is that mucus that got lodged where there was a bifurcation, where there was a split in the bronchioles, right? Because obviously bronchioles are kind of like roots. They keep on getting smaller and smaller. And it occluded, okay, the bronchiole over here completely. So that whole area of the lung was not able to ventilate. The same thing over here. Now, that's not the most common thing in asthmatics. That's more like people have cystic fibrosis and stuff like that, where they get these huge mucus plugs. But we really serve no benefit to our patients, especially our asthmatic patients and our pediatric patients, by giving them oxygen that's not running through a humidifier. You've never, ever saw somebody in the hospital where they are getting oxygen. Okay, hold on one second.
I figured it was important, so I didn't. It was important.
Okay, I'm going to just mute everybody. Where they would be getting oxygen that's not running through a humidifier, right? It's just not medically acceptable because oxygen of an oxygen tank has 0% humidity. So everybody's going to say, like, why do we do that then? So, most of the times EMS transports are probably under 15, 20 minutes. And that 15, 20 minutes exposure, a patient's exposure to, non-humidified oxygen is probably not going to make a big deal. So personally, I try to put patients on humidified oxygen if they're an asthma patient. All pediatric patients that are getting oxygen should probably be on humidified oxygen and stuff like that. So the real big ones, I would say, cystic fibrosis, which we don't have that often, asthma patients, pediatric patients. The humidifiers of today are one-time use disposable, little containers of water that we screw onto the oxygen. It only works on the oxygen in the ambulance. Don't even bother trying it in the house. But off the wall oxygen in the ambulance, you take off that little green nipple that the tubing usually goes on. You screw the nebulizer, I'm sorry, not the nebulizer, the humidifier onto it, and then the water now runs through, the oxygen runs through the water and off the actual container of water. Let me actually, instead of talking through it, let me see if I could actually find one for you. Let me just see if I can. Okay, just screen share it. Now, I don't know, do you have humidifiers on the ambulances? Does anybody know? So basically, it's this bottle of water. Okay, I don't want it to magnify, but it's magnifying. This bottle of water here, okay, and it has this little attachment. So what you would do, let me just move it down a little bit, is up top, if you look at the, if I move the mouse, I'm going to lose the magnification, but right up top here, there's two tear-offs. The one up to the left, okay, is where this little device down here screws onto. So this part down at the bottom basically screws onto this piece up top here, okay? The other piece to the left, you kind of, that tab that's hanging down, you rip off, and that's where the oxygen will be coming out of. So this piece here would, when you remove the green nipple off your wall oxygen, you screw that in place of it. The oxygen then travels through the water, just like a kind of like a, looking like a fish tank, starts to bubble. And then the oxygen comes out the top up here and, goes through your tubing into the patient, and it obviously picks up the water, so it has some humidity in it. So that's what the device would basically be. Now, they're one-time use disposable. Years ago, the problem was that the devices were not disposable, so we would put water in them. And, at the end of it, we were supposed to clean them, and sometimes the water stayed in there and bacteria grew and stuff like that. But, now they're one-time use disposable. I think they're like $8 a piece and stuff. And it's just, again, with asthma patients, pediatric patients and stuff like that, it's probably the better way to give them, oxygen. Okay, so that's another issue that some asthmatics have. Okay. Make sure I got this going. Okay, so as far as the different triggers of asthmatics and stuff like that, there's varied ones, but the most common one would be allergies to certain substances. Okay, colds or infections obviously are a stressor on an asthmatic. Just general stress, exam anxiety, work anxiety, exercise induced, the changes in the seasons, right? So we know now that we're going to be going into spring, the warmer, humid weather, the pollen, the dust, and stuff like that. Okay, will all be triggers for, asthmatics and stuff like that. Now, what do we see? So the most prominent, I guess, sign that we would see, or a sign is really something you see, but I guess, something you hear would be wheezing, right? So wheezing is a whistling sound when air is traveling through a bronchiole. So it's kind of this similar sound to if you put your fingers to your mouth and blow air through it gently, you make kind of a whistling sound. In asthmatics, usually wheezing starts on exhalation, and as they get tighter, they'll have both inspiratory and expiratory wheezing, and it's for a pretty simple reason that when you're breathing in, it's a very forceful process, right? You're sucking air in, and you actually open up the bronchioles a little bit, so you don't get that whistling sound. But when you exhale, it's a passive. Your muscles, your chest, your diaphragm, and stuff are just relaxing. It's a very passive, so it's not pushing air through the bronchioles with the same force. So that's why you get the wheezing. Typically, it starts as expiratory. As they get tighter, it will be inspiratory and expiratory wheezing. Tachypnea, the rapid breathing, obviously is a compensatory mechanism. The tachycardia is a response to when somebody feels like they can't breathe. Obviously, they get a little nervous, so they have a little adrenaline flowing. Cyanosis would be a very, very late sign of asthmatics, so you would not see it early in asthma. It would only be somebody who's really having major problems. We'll talk about the different stages of asthma. Now, there is one type of asthma called cough variant asthma. It's not that common, but in people who have cough variant asthma, don't wheeze as much as they cough. And it's not a hacking cough like when you have bronchitis. It's a very weak, ineffective cough. If you've ever given anybody an albuterol treatment, when they start to open up, they also do this kind of like weak, ineffective cough. So you know that the albuterol is starting to work. It's kind of like a type of cough where they can't really get a full, forceful cough out. So that's kind of what happens in cough variant asthma. It doesn't really matter as far as treatment goes. Albuterol would still be the treatment of choice, whether it's wheezing or cough variant asthma. So it doesn't, necessarily matter, what the sound that you're hearing is. Either one would be appropriate. Now, when they start getting worse, we're going to see accessory muscle use. So you know that your primary muscles of breathing are your diaphragm and your intercostal muscles between your ribs, right? Those are your primary ones. And kids, their primary muscles are really just their diaphragm. They don't start using their intercostals till they start getting towards puberty. So if you see a patient using any other muscle other than their primary muscles, that would be accessory muscle use, which means that they're struggling to breathe. They're trying to use other muscles to help them to breathe. Patients who are extremely short of breath cannot speak to you in full sentences. So you ask them a question and they kind of give you the one-word answers and stuff like that. That, is another reliable sign of somebody having, trouble breathing. And obviously, if the patients are at that point, then, questioning interaction with them as far as speaking should probably be to a minimum, maybe just allergies and stuff like that, just so you don't administer a medication they may be allergic to. Obviously, they're anxious because of the hypoxia, right? So they don't follow commands well. The classic thing that we've all experienced is we put them on a non-rebreather, trying to give them 100% oxygen, they rip it off, right? Because their problem is they don't feel that their oxygen level is low. They feel they can't get a good breath of air in. And when we put a non-rebreather on them, it feels confining to them. Even though it's giving them 100% oxygen, it's not giving them 100% oxygen with a lot of flow. So they just feel like you're making them worse. You're kind of suffocating them. Now, CPAP can be used in asthmatics. The problem with CPAP, if you've seen it compared to a non-rebreather, the mask is probably twice as big and much more claustrophobic. So it's a little harder to sell them on the idea of keeping the CPAP on. But once they keep it on and start working with it and breathing with it, it definitely will help them, and they'll comply with it, because what happens is when they go to take a breath in, it's almost like forcing air into them. So it takes away that anxiety of not feeling like they can get a deep breath. But for that first minute, when you first put it on them, it's very hard to, convince them to keep it in place. The other problem sometimes with CPAP is that the pressure in, right? In other words, when they breathe in, the pressure in is the same as the pressure out. So that it's a little harder for them to exhale than it would be without CPAP on. And since asthma is really an expiratory problem, because, we said the issue of wheezing, like we hear more expiratory wheezing, it's harder for them to get air out. It can make it a little more difficult for those patients. Asthmatics would really do better with something called BiPAP, which is a better version of CPAP, where that when they exhale, it actually cuts the pressure down. It makes it easier for them to exhale. The reason we have CPAP in the field and not BiPAP is that CPAP can be a disposable device, one-time use, runs off of an oxygen tank. BiPAP requires a compressed air source. You need like a ventilator type of thing to be able to use BiPAP. So that's kind of why, or like, at least some kind of compressed air source. And again, we want to give them oxygen, so we just can't use like room air. So that's why there's not like a BiPAP version of it. I mean, somebody will invent it. There's no doubt about it, but right now there's not. They have that prolonged expiratory phase, again, because it's just harder for them to get air out. And they say it can take them 2 or 3 times as long to exhale as inhale. And because it's harder for them to exhale, they retain CO2, right? Because we rid our body of carbon dioxide on exhalation. So they do tend to have higher levels of carbon dioxide, and carbon dioxide that remains in the body kind of acts as a sedative on a patient and decreases their mental status, decreases their drive to breathe. So that's not good in somebody who's struggling, to breathe. And we'll talk about the end stages, the bad stages of asthma. Asthmatics, COPDers, chronic patients who have breathing problems all their lives, just naturally learn by survival what positions feel most comfortable for them to breathe. So a lot of times you'll see asthmatics and also COPDers, emphysemics and stuff like that get into what they call the tripoding position, where they're kind of have their arms down along their side, pressing on a chair or something so that they actually raise their chest up a little higher, so they bring their diaphragm down a little lower. And by bringing their diaphragm down a little lower, they actually get a few more milliliters of air in. And to us, it wouldn't notice to be a big difference, but for them, every milliliter of air is very important. So you may find them in that tripoding position. And in smaller patients, when patients have problems sucking air in, you may see some nasal flaring where the skin over here on the nose, kind of flares in and out as they breathe in. So those are, all different signs. Again, nowadays, really bad asthmatics, not so common. The reason why you may come across a bad asthmatic, and if anybody is an asthmatic, in class tonight, I apologize in advance, but what happens is asthma patients, for some reason, and I think I know the reason, try to treat themselves at home. And they really try to prevent themselves from going to the hospital. And they typically only call the ambulance when their treatment has failed. So by the time we get there, they're further into their asthma attack and they're bad, right? They're not in the early stages. So, you can run into the situation where you can show up on an asthma call. The patient may or may not be truthful and, may say, you've only been having breathing for 20 minutes, where it may be, 6 hours. But most asthmatics, don't routinely call to be brought to the hospital just because they're having an asthma attack. They try to treat themselves with their various different medications they have at home before, like in other words, going to the hospital is not a first thing they would think of. It would be the last thing they would think of. So sometimes we do get there and they're pretty far, into their asthma attack and pretty sick. And, to the point sometimes where, they're dying and our treatment may not be useful, especially in a BLS level. Like you can't give somebody an albuterol treatment who's not breathing deeply anymore, who's not conscious anymore. So they may be at the point where, your treatment is going to be bagging them. And thankfully in the new protocol update they put in, we can actually use the Epipen on dying asthmatics. And we'll talk about, when we could do things on standing orders and when we could do things on medical control options that we have to call the hospital. Now, the patient that sits home and is struggling to breathe gets into this stage of breathing called respiratory muscle fatigue. So just like if you were to start lifting weights, right, at a certain point, your arms do not function anymore, right? The muscles are used up. And what happens is that, when you muscles do something, there's a process called metabolism. Metabolism is the burning of sugar and oxygen to make energy, right? So normal metabolism is called aerobic metabolism, like, aerobics exercise, okay? And it's the burning of oxygen and sugar to make a substance called ATP. So ATP is kind of our adenosine triphosphate, is kind of our energy molecule. And when we make energy with aerobic metabolism, which is what we're doing right now, we make a decent amount of ATP, and the waste product of that burning of that ATP, to make energy is carbon dioxide and water. So we can get rid of it very easily, right? We can exhale our carbon dioxide and we can urinate out our water. But when somebody has an asthma attack, right, it becomes harder for them to get rid of that CO2 because they can't exhale well. And as they continue to struggle to breathe, what happens is the normal metabolism changes from aerobic with oxygen to anaerobic without oxygen because they're not bringing enough oxygen in. And now they still make energy, just don't make enough of it, right? They don't make as much as they did if they had oxygen, enough oxygen present. But also they get a secondary waste product called lactic acid, and it's much harder for the body to get rid of lactic acid. So just like if you picked up some dumbbells and started curling, at some point you're going to get a burn in your muscles, your arms are going to start shaking, your muscles are not going to be able to lift those weights. That's what happens in the diaphragm and the intercostals when a patient's having an asthma attack and they've been struggling and breathing real hard for hours, okay? They move into this stage. And then these are the patients that stop breathing, right? Their muscles, but before they completely stop breathing, they start to shallow breathe. And what shallow breathe means is that, you all know we bring in a certain amount of air with every breath, right? So that's referred to as tidal volume, the amount of air you bring in with each breath. Most of us, our tidal volume is between 400 and 500 milliliters of air, okay? About the size of a, water bottle, regular little water bottle. Now, if your muscles are weakened and they can't bring in that same tidal volume, what starts to happen is you have poor gas exchange because you need a certain amount. You need 150 mLs of air to get air from your nose down to your alveoli, right? So when you breathe 500 mLs, about 150 of it doesn't actually get to your alveoli to your second breath. It gets kind of stuck in your airway passageways. And then on your second breath, obviously, you push that 150 down, and then another 150 gets stuck there. So if you're only breathing, instead of 500 mLs of air, because your muscles are tired and you can't breathe deep, you're only breathing 300 mLs of air, right? Because you have ineffective muscle use of your diaphragm and intercostals. Now, instead of, before we had, say, 350 making down there because we were breathing 500, 150 got stuck in a dead air space. So we got 350 down to our alveoli. If you're only breathing 300 because you have decreased tidal volume, that means 150 still has to get stuck in your dead air space. That means only 150 is left for gas exchange. And this starts a very, dismal process, which the hypoxia starts the heart beating slower and weaker, and they basically, eventually go into cardiac arrest from it. Their heart doesn't go into VFib usually. What happens is they start getting the heart slower and slower bradycardia to the point where they're just not beating enough times a minute to circulate blood. And remember, the blood that is being circulated is not high in oxygen because of the asthma attack. And this is how, the patients die who are having, asthma attacks. Now, sometimes it's a little hard for us. We walk in and it looks like the patient's breathing. How do we judge that they're breathing shallow, right? We don't have a device to measure the amount of air they're breathing in. So you could say, chest rise and all that kind of stuff. But obviously, if you're retaining carbon dioxide and you have low levels of oxygen, your mental status has to be depressed, right? You have to start, moving towards sleepiness, getting drowsy. So that's probably the first sign when you walk in a house. If you have a patient who's having a respiratory problem, you've all seen people having trouble breathing. They're wide awake, they're anxious, they're concentrating on every breath. But if you have a patient who has a respiratory problem and they're not wide awake and just wanting to sit upright and struggle to breathe, they're probably in this later stage of, their breathing problem, whether it's asthma or something else. And, at that point, if they're already laying down, they can't even sit up anymore. It's probably too late to try to give them an albuterol treatment because they're not breathing deep enough in. That's where you're probably going to be going to your bag valve mask and trying to ventilate them and raise their oxygen level, blow off their CO2. And if you're successful, what you'll find is that they start pushing the bag valve mask away from their face, right? They're like, what's this guy doing to me? And that's a good sign, right? So you sit them up, okay, and you put them on regular oxygen and now give them an albuterol treatment, because what you did is you raised their oxygen level and lowered their carbon dioxide level to the point where they're functioning again. Now, CPAP is a good device to prevent them from getting to this, right? I mean, in other words, if you can convince an asthmatic who's, it's not a mild attack, but a severe attack, but not at the point where they have respiratory muscle fatigue. If you can convince them to be on CPAP, what's going to happen is it's going to increase their tidal volume, and they're not going to have that problem with not bringing enough oxygen in and not removing enough CO2. But again, it requires you to be comfortable with using CPAP, which most of us are not because we don't use it enough. And we don't practice with it enough, okay? And, you have to kind of be a good salesman and sell the patient on using it, right? Because they're going to be scared. They're not going to be processing information appropriately. Now, the worst stage is something called status asthmaticus. Status asthmaticus is somebody is not responding to the bronchodilators, to the albuterol, right? So they're just having this prolonged attack that is not breaking, and you're giving them repeated albuterol treatments. You brought them up to the hospital, they're giving them albuterol and it's not breaking, okay? So those are patients that are just all of a sudden going to die on you. They're going to stop breathing. Remember, they have a high CO2 level, low oxygen level. They're struggling to breathe. Their muscles are getting weak. They're not going to be a patient who's sitting up, conversing with you saying, please help me, I'm having trouble breathing. These patients are bad. They're not at that point anymore. Now, years ago, there wasn't really anything we do for them. Like even trying to intubate them was hard and stuff like that. So what they've decided to do is into the new BLS protocol that came out last year is they included EpiPens. So why is EpiPen useful in asthmatics? So just, as a little background history, before we had albuterol, albuterol is only probably out about 20, 25 years. Before we had albuterol, we gave every asthmatic a shot of epinephrine. That's how we treated them. Epinephrine does a couple things. It actually relaxes the bronchioles, just like albuterol does. So it's a good bronchodilator. It also relaxes your upper airway, your larynx. So that's not useful in asthmatics because they don't have an upper airway problem. But say in anaphylaxis, it's also works on the upper airway. So it's great for anaphylaxis because you got both upper and lower airway coverage. And then in anaphylaxis, it constricts the blood vessels. And in anaphylactic shock, the reason they're dropping their blood pressure is they have vasodilation. So it's a great drug in anaphylaxis. It's a good drug in a dying asthmatic because you're going to get that bronchodilation. What's not good about it, and the reason we went to albuterol, is that the side effect of a shot of epinephrine, as you know, is that it basically strains your heart, right? It makes your heart beat harder and faster. And when somebody's hypoxic, you don't necessarily want to make their heart run harder and faster. And have a mismatch between the amount of oxygen the heart needs and what it's getting, because you could trigger people that have chest pain and ischemic, cardiac changes and stuff like that. So once they came out with a drug like albuterol that kind of works on the bronchioles just as well as asthma, but is not quite as doesn't quite cause the same amount of tachycardia, we switched from epi to albuterol. And for years, we never used epinephrine on asthmatics. But what they recognized is that there needs to be some treatment for asthmatics who cannot use a nebulizer, right? Who cannot breathe in that albuterol anymore. And that's these, respiratory muscle fatigue patients, these status asthmaticus patients. So epi is back into the BLS protocol, but since it's so rare that you would ever need to use it, they made it a medical control option, which means you have to call for permission to use it. But everything's pretty much the same as in anaphylaxis, except that you have to call. So the dosing is the same, right? Now we know we have an adult dose and a pediatric dose. Does anybody remember, the difference between the adult dose and the pediatric dose? Does anybody remember the numbers or anything like that? And when we would use it? So the difference between adults and peds in medicine most of the times is not age, is weight, right? It's very rarely is it age. So the weight that we would be looking for is 30 kilograms, which works out to about 66 pounds. So if they're over 66 pounds, we give them the adult dose, which is 0.3 milligrams, and I'll show you that in a second. And if they're under 66 pounds or 30 kilograms, we give them the pediatric dose. Okay. But again, you have to call medical control. You're going to have to describe the situation that, patient was having an asthma attack for hours. They're now semi-conscious. They can't use the albuterol. Their pulse ox is 84% or, 80%. They're cyanotic, they're not moving any air. We can't ventilate them because they're, they're so tight and they're dying on us. Can we go ahead and use the epi auto injector? And the answer, hopefully would be yes, because that would be the appropriate treatment in those patients. So you give them the intramuscular injection of epinephrine. Again, remember that, the EpiPen that a patient is taught to use, they're always taught to inject it in their thigh, okay? But blood flow below the diaphragm is much slower than blood flow above the diaphragm. So when you were trained to do check and inject, okay, you were trained to give an intramuscular injection in the deltoid muscle. And I know that I don't remember whether we ever got to it or not before COVID by you guys or not, but it was one of the things we were planning on doing it. But, intramuscular injections, on an EMT level are standard of care, right? They're taught in every EMT class now. That's why EMTs are allowed to give vaccines, in this emergency COVID setting and stuff like that, because you're already trained in giving intramuscular injections. But giving it in the deltoid muscle of the upper arm would result in the medication being absorbed much quicker than it would be giving it in the leg, okay? Just because blood flow below your diaphragm is worse, right? You have to, in other words, you inject it in their leg, the veins have to bring it back up through the stomach, through the diaphragm, back up to the heart to get recirculated. So it's just to be a quicker action to give it in the arm than it would be in the leg. Okay, so if you had that situation where you have this dying asthmatic, it would definitely be more appropriate to give a deltoid injection than a quadriceps injection. Okay, so we're talking about now these lower airways, these yellow tubes, these bronchioles that come into the alveoli, right? And you know that the alveoli are the multi-roomed bags, so to speak. In other words, they're not just one big hollow bag. They're bags with multiple rooms in them because the gas exchange takes place in the walls, because running through the walls are all the capillaries. And the capillaries obviously are the blood vessels that, allow the exchange of, oxygen, carbon dioxide, nutrients between the cells and the alveoli. So, we're talking about really problems in these terminal bronchioles that come down into the alveoli, and we're talking about an asthma attack. Now, as far as nebulized albuterol goes, we've been allowed as EMTs to use albuterol probably for close to 20 years. It was based on an increase one summer of deaths in New York City. They had a lot of pediatric asthma deaths in New York City. One summer, the newspaper got a hold of it. There weren't a lot of paramedic ambulances, so they decided to train the EMTs to use albuterol, and it was a huge success, right? Very, very, no bad outcomes, only everything positive by using it. So they expanded it from New York City to the entire state. The problem was that the old protocol specifically said that the patient had to be between the ages of 1 and 65, have a history of asthma, be having an asthma attack, and be wheezing, right? So the new protocol basically says that you can use it in any patient who's wheezing. Don't worry about age. Don't worry about whether or not they have a history of asthma. If somebody's wheezing, albuterol would be the appropriate drug. And remember, we said before that there is what they call cough variant asthma, where instead of wheezing, they cough, and it would be also appropriate to give them albuterol, okay? So the new nebulized albuterol protocol just says any patient who's having respiratory distress accompanied by wheezing can be given albuterol, okay? To use albuterol, the agency has to apply to the region for permission to use it. It's just a piece of paper. And then obviously you have to have training in using it, okay? And the albuterol dose that we give patients at all ages, doesn't matter between peds or adult, is 2.5 milligrams. It's dissolved in 3 mLs. It's pre-packaged. I'll show you some pictures of it, but it's pre-packaged, so you don't draw up anything. You just kind of open it and pour it into the nebulizer. And typically we run a nebulizer at 4 to 6 liters per minute. Most people run it at 6, but 4 to 6 liters per minute. Under 4, it doesn't actually nebulize well, doesn't turn it into a mist, and over 6, you're just wasting it. You're not going to be there. You're not going to get good usage of it. Okay, you don't have to stay in the house to finish albuterol treatments and stuff. You can give it en route to the hospital. Okay. And with the new protocol, we're up to 3 doses that we can give on standing order, right? The old protocol was 2. The new protocol, you can give back-to-back albuterol treatments, right? 5 minutes apart. Takes about 5 minutes to finish the treatment anyway, back-to-back. Again, I know in Piermont, it would be highly unlikely that you wouldn't be at the hospital probably before the 1st or 2nd, but if for some reason you're delayed, you can give up to 3, and you could also call for medical control if you need to go beyond 3 for permission to use, more than 3 doses. So albuterol, again, great drug, works very well. You would like to instruct the patients when they're using it to breathe it deeply and hold it for a second. So like they may not be able to do that every breath, but say every 3rd, 4th, 5th breath, just take a deep breath, hold it for a second, because they want to hold it down in their alveoli so it gets absorbed by the blood vessels. And what'll start happening is, again, as they start to open up, you'll see that little weak ineffective cough. That's a good sign, okay? And they're just going to progressively be able to move more and more air in. And we want them to feel 100% better. Like if they say, I'm feeling a little better, you're going to give them a second albuterol treatment. You do not have to fear giving, back-to-back albuterol treatments. That's what's going to be done from the hospital. They'll continue to get albuterol treatments till they're 100% wide open, having no respiratory distress. Yes, the more treatments they get, the more jittery they're going to feel, the more tachycardia they're going to have, but it's a better feeling, than the feeling like you can't take a deep breath and stuff like that. So albuterol is a bronchodilator, only works on the bronchioles, right? Doesn't work anyplace else. So again, if somebody was having stridorous sounds, upper airway sounds, albuterol would be a useless drug to give them. Like, so if you had a croupy patient or something like that, it wouldn't help giving them albuterol. They need epinephrine. Okay, but for this situation in asthma, since it's a bronchial problem, it's a great drug. It does definitely make people jittery, nervous. Their heart does race a little bit and stuff like that. There's no doubt about it. There are some patients who say, oh, do you really have to give it to me? I hate the way it makes me feel. And you just tell them, what do you want to feel? Do you want to feel like you can't breathe, or do you want to feel a little jittery? And they have to make the decision. Obviously, if they refuse to allow you to treat them, you can't treat them, but they have to make that decision on what they want to treat. Again, it comes pre-packaged, right? It is a unit dose where there's 2.5 milligrams of the albuterol dissolved in 3 milliliters of normal saline. We're going to run the nebulizer at 4 to 6 liters per minute. Again, most of us run it at 6. Okay, and you can give up to 3 doses back to back, 5 minutes in between, or about the time it takes you to finish the albuterol treatment. Okay, so as far as putting the nebulizer and all the medication together, that's more of something better to do in a classroom setting. So when we at some point, I don't know if we'll have every class in person anymore, because it seems like a lot of people still like the luxury of being in their homes and having the Zoom sessions, but we should probably at least every quarter maybe meet once just to do skills, right? Just to go over the stuff that we don't routinely use, the CPAP and the nebulizers and EpiPens and all that kind of stuff. Okay, so we'll go over how to use that and everything like that. Now, the addition to the protocol that I was alluding to before was the use of the EpiPen in asthma, right? So up until this protocol change last year, we could only use the EpiPen for anaphylaxis. Okay, so in anaphylaxis, it's always a standing order. Okay, you can give up to 2 doses on standing order in anaphylaxis. In asthma, since it's so rare that you have that severe of an asthmatic patient that's dying, they want you to call medical control. But everything else is the same, right? If they're over 66 pounds, you use the adult. If they're under 66 pounds, you use the peds. Again, the adult dose is 0.3 milligrams. The pediatric dose is 0.15 milligrams. But again, just that it's a medical control option. So this is going to be somebody who is dead or soon to be dead from an asthma attack, and you need to get them open as quick as possible. Okay. And again, the bad part of epi in somebody who's having trouble breathing, like an asthma attack, is that it increases what's called the myocardial oxygen demand. So at any point, your heart, your myocardium, right, your heart muscle needs a certain amount of oxygen. Us sitting here talking, very little. If you decide to exercise while I'm talking and make use of the downtime, then obviously your heart needs more oxygen. Okay, so the issue in an asthma patient is that they're probably a little tachycardic because they're scared, right? And they can't get enough oxygen in. So now you hit them with epi, which basically is jamming down on their gas pedal and making their heart rate go from 60 beats per minute to 150 beats per minute. So if your heart's beating 3 times as fast as it was before the epi, obviously it needs more oxygen to be able to beat that fast. So you can have a mismatch in that, and that can cause ischemia, can cause the muscle to have too little oxygen. And people can have chest pain, they can have heart attacks, they can have death. But it's rare, right? I mean, again, we typically have our asthmatic patients on oxygen, so hopefully our pulse oxes are close to normal, and we're only doing this on the dying patient. So I could just tell you, in all honesty, I've never given, an epi shot since this new protocol came out to a dying asthmatic. Before we had albuterol, like I said, every asthmatic got epi. I never had an asthmatic that I gave epi to tell me they had chest pain. So it's not a common, problem, but it can happen. I did have a patient dying of anaphylaxis who we gave epi. Instead of giving it as an injection in their arm, we actually gave it intravenous through the IV, where their EKG changed to look like they were having a heart attack. They were not able to talk to us because they were pretty far gone, but the patient survived, and they did not have a heart attack. It just looked like they were having a heart attack because the heart wasn't getting enough oxygen temporarily because of all the epi, right? It was stressing their heart. So it was very nerve-wracking for us. The patient didn't know what was going on because they were dying. We were like, oh my God, we just killed this guy trying to save him. But everything turned out, thank God, to go, work out for the best in the patient. He survived and everything like that. So, it can happen, but it doesn't routinely happen. Okay, so any questions so far on anything as far as the asthma or anything like that, or the treatments or anything? So again, adults are over 66 pounds, peds are under 66 pounds. If you're using the adult dose with an EpiPen, you're giving the adult EpiPen. Pediatric, you're giving the EpiPen Junior, right? They're labeled. The EpiPens, adults have 0.3 milligrams. The pediatrics are 0.15. 0.15 is actually half of 0.3. So you're giving them half the adult dose. And again, if you're doing check and inject, which I don't think we ever got to, but you know, you would be drawing up the appropriate amount in a syringe to give it and stuff like that. Whoa. I don't know what happened there. Okay, so that's basically everything with the asthma patients. Does anybody have any questions on anything as far as the asthma patient goes, or the treatment, or the drug dosing, or anything like that? Okay. So let's just do 3 quick abdominal emergencies, and we will call it a night.
Frank,
And that is not my stomach. Go ahead.
can you hear me?
Yes, I can hear you.
We just changed our Epi back to the Avi ones. So we are not going with check inject. We decided not
Good.
to.
Good.
Because we figured it was harder for people to learn whatever. So we are staying, and we just went back to the Avies, which are even easier than what we currently had on there. Those are dummy proof.
Okay. Perfect. So
So-
again, you know, so at some point, you know, we'll have an in-person class session where we'll go over.
Yes, and I have the trainers for them.
Yep, we'll go over that, and you know, the CPAP and whatever else we want to, you know, include the albuterol treatments and stuff like that. The things that we don't routinely, you know, get to practice because of the slow, you know, call
Okay.
volume and stuff like that. Okay.
Okay.
Let's do a couple abdominal emergencies, and then we'll call it a night. Okay, so the first one we're going to talk about is abdominal aortic aneurysm. So they call that the AAA, right? So, you know, if you've done medicine for long enough, you know, you'll always hear somebody say they had a AAA or something like that. So you know that the aorta is the largest artery in the body. It originates off the left ventricle, and your left ventricle, interestingly, like when you learn in class, you always think it kind of pumps out the bottom over here, but it actually, the way the left ventricle sits, it actually pumps upwards. So it's pumping upwards into the aorta, and then the aorta actually arches, right, as soon as it comes off the left ventricle and goes behind the heart and goes downward. And when it's behind the heart, it's actually right in front of the spine. So when people are having a problem with their aorta, they actually usually have back pain. So you can have an aneurysm in the thoracic area of the chest, but tonight we're going to, since we're doing abdominal emergencies, we're going to talk about when there's an aneurysm in the area of the abdominal cavity. So that's why it's called an abdominal aortic aneurysm. So because the aorta is a high pressure vessel, right, it's susceptible to having, you know, problems where there could be bulges in it. Okay, now it's not common, obviously. It can happen. Any artery can have an aneurysm in it. You've heard of people having aneurysms in their head, right, and it bursts and they have a bleed in their head and stuff like that. So any artery, because it's a high pressure vessel, can have an aneurysm. It's just more common in the aorta because the blood pressure of the aorta is the highest blood pressure in your body. So as it comes down into your abdominal cavity, okay, about at the level right below your belly button, it bifurcates or splits into your iliac arteries that head down towards your legs, and then obviously your iliacs turn into your femorals, and so on, right? So that's kind of your vasculature, you know, off your aorta. So this CAT scan picture over here, here's the aorta coming down, right, past the kidneys. And this is the area now where the aneurysm developed in this patient. And actually, when they talk about a dissecting aortic aneurysm, it means that as the walls, what happens when there's an aneurysm is that there's 3 layers to the arterial wall. You know, any arterial wall, there's an inner, middle, and outer layer. What happens when somebody has an aneurysm is that the inner layer starts to weaken and gets a tear in it, and the blood works its way between the inner layer and the middle layer, and it starts to make an artificial pathway, and I'll show you what I'm talking about in a second. But what happens then is that you get this distinctive bulge, just kind of like if a tire gets a weakened area and you get a bulge on it. And obviously the risk, well, there's twofold risk. You know, one is obviously bursting, which usually would be instantaneous death, okay? Or what happens with the dissection, let me see if this slide is a little better. This one's a little better actually. So here's a nice clean artery, right? So you've got a nice clean lumen. And because of old age or high blood pressure or vascular disease or something, they get a little nick on the inside of it. And that, remember, the pressure in this blood vessel is very high. It's the highest blood pressure in your body. It starts to tear this little nick and peel it away. And what it does is it makes a little pathway starts to dissect or split the different layers of the walls of the arteries. And it's trying to make this is called the lumen. This is where the blood flows through. It's trying to make another lumen, like another place for the blood to go. Okay, so they're going to get a bulge out over here. Okay, but the other risk that could happen is that if it gets large enough where blood could sit up here, it will clot. Blood clots pretty quickly. So blood starts to splash up in here, but doesn't continually flow, right? Because it's just got this little nick, it can't flow. They'll get a clot. If the clot breaks loose and flows out, okay, now they have a problem with a free-flowing clot. So if it happened like where they're showing you over here, right before the arch, this patient will probably have a stroke. In other words, it would come up into one of these 3 branches off the arch of the aorta. These all go up to the brain or the arms or something like that. So they'll probably have a stroke. We're talking about that it's down in the belly. Okay, so they would probably go down into the iliac, the clot, and the patient would call you and say, you know, I'm having lower back pain, and now all of a sudden one of my legs went numb. It's cold, I can't move it, you know, and stuff. So what they're having an aneurysm, they got that artificial channel that built up, and that's what happened with this guy, it looks like. And he threw a clot probably down into a branch of his iliac, and his leg went numb. So, you know, sudden leg numbness with you know, lower back pain can always be indicative of a abdominal aortic aneurysm. So what do we look for, you know, as far as signs and symptoms and stuff? Now, just so you realize, we could all have aneurysms in our body and be totally asymptomatic, right? There's no way to know if you have aneurysms anywhere in your body, okay, without getting a CT angiogram. So you have to get a CT with dye injected in you, and then they could see. So that's just not routinely done, right? I mean, you're not going to go in and have a top to bottom CT unless you go to like that Princeton Longevity Center, you know, where they do like a top to bottom, you know, whatever, $5,000 workup, and you have, you know, a top to bottom CAT scan and all this stuff. And even with that, they're not doing a CT angiogram on you. They're just doing a plain Jane CT. So they may miss small aneurysms, right? Because with an angiogram, they're injecting dye, which kind of makes the blood vessels light up a little better. So most of us would not know if we have any aneurysms or anything anywhere in our body. When they start to dissect, then you get that tearing pain because the walls of the arteries are starting to rip apart, and, you know, patients then have pain and stuff. So, but what you can see, you know, and stuff like that, when somebody has a really legit abdominal aortic aneurysm, is you can palpate or sometimes even see the aorta coming to the surface. Now, this could be a hernia, or this could be an abdominal aortic aneurysm. The difference is if it's a hernia, it's not going to have a pulse to it because it's not a blood vessel. A hernia is an abdominal organ, right? It could be your intestine typically, that goes through a weakened muscle in your wall of your abdomen and kind of starts to protrude. So if you touch this and there was no pulse to it, it's probably not an aortic aneurysm. If you touch this and there was a pulse to it, then it is an aortic aneurysm. But most of the times it doesn't come to the surface. But if you look at this gentleman's CAT scan, you could see why, you know, it's showing on the surface of his abdomen. That's pretty rare. I've never seen that in my life. But that's, you know, that's definitely something that happens. So patients typically describe, you know, a sudden onset of like tearing abdominal pain, excruciating in you know, level of pain and stuff like that. They can also talk about the, you know, the cold, numb limb. If they threw a clot, that's not always, but if they threw a clot, that can happen. Okay. Now, what causes somebody to be at risk for an abdominal aortic aneurysm? So really, it's high blood pressure and old age. Okay, pretty much. If you looked at percentage of abdominal aortic aneurysms, people are in probably their 60s, 70s, 80s, and stuff like that. And they probably have some high blood pressure as a contributing factor, because obviously the higher the blood pressure, the more force on the inside of the wall of the blood vessel. Now, other things contribute to it. So tobacco use, the nicotine in tobacco is irritating to the blood vessels. Okay, it's and the tar part of the cigarette is irritating to the lungs, to the bronchioles. If they have any vascular disease, so if they tell you that they had a heart attack in the past, a stroke in the past, or anything like that, or they have phlebitis or anything like that, any kind of blood vessel issues makes it more likely for them to have this issue. Okay, if they actually have an infection in their blood vessels, vasculitis, high blood pressure. Okay, now what are the risks of an abdominal aortic? So the major risk is rupture, right? So if you had a rupture of an artery in your brain, right, you would have a stroke, but you'd have a wet stroke. Most strokes are dry strokes, where it's just a clot. But, you know, you would just have the same thing as if you had, you know, head trauma with intracranial, like a subdural epidural hematoma, right? You could have a wet stroke that develops into that. It could be from a fall, or it could just be from a ruptured blood vessel. We had in Rockland County at one point a EMT riding on Nyack ambulance. They had a call in the tiered parking lot at the Palisades Mall, and the guy who was driving the ambulance was not the smartest guy, and he tried to bring the box ambulance into the tiered parking lot, so he didn't make it past the wall. So he hit the box on the wall before he even entered the parking lot, and the girl, the EMT, was not seatbelted, and she hit her head on the dash. And she was dazed, she was fine, everything was okay, but just out of an abundance of caution, they convinced her to go to Nyack. She had a chronic headache, so they did a CAT scan on her, and they found that she actually had an aneurysm in her brain, totally asymptomatic, had nothing to do with the injury. It was probably there from, she was 20 something at that point. It was probably there for years. And at some point that could have ruptured, right? It wasn't huge at the point that they found it, but in her life, later in life, it could have gotten bigger and ruptured. So it's just a fluke that because of the accident that it was diagnosed. It had nothing to do with the accident. It wasn't from the accident or anything like that. So, it's not uncommon for people to have aneurysms. There's also a higher risk of people have what's called AV malformations, atrial venous malformations. That arteries don't directly connect to veins, right? Between arteries and veins are your capillary beds. So that what happens is the high blood pressure of an artery is dispersed through the capillary beds and nourishes everything that's supposed to get nourished. And then the low pressure at the end of the capillary bed goes into the vein. So there's never a problem with a vein being exposed to arterial pressures because the blood flows through the capillary system before it ever gets into a vein. People have AV malformations. They have an abnormal problem where the artery connected directly to a vein. So now that at that connection site, it's very likely to develop an aneurysm. So people who have AV malformations are more likely to have aneurysms. Again, there's no way of knowing without invasive, not invasive, but without CT angiogram type of testing. So we could all be walking around with those types of things and not know it. Okay, so again, the biggest complication would be rupture. Dissection is where it starts to tear away and makes that bulge, and the bulge obviously was what leads to the rupture. Okay, clots are a secondary problem that can develop. Sometimes clots can be like almost life-saving in a way because the patient may have back pain and just decide that it's because they lifted something the wrong way, and now all of a sudden their leg goes numb, and that's what triggers them to call the ambulance. Where before they may just sit home saying, "Oh, I have back pain because I have back pain. I did something." Although it tends to be a pretty excruciating pain, people typically realize it's something more than just a muscular problem. Now, palpating for an abdominal aortic aneurysm is a little different than palpating for problems in the stomach like we normally do. So when we normally palpate, we kind of go like this. If you were to do that on the stomach of somebody who had an aneurysm, you would actually just push the aneurysm away from your hand and you wouldn't feel the pulsation. So the aorta runs down the midline, right? So it's kind of deep in because it's right above the spine. So the only way you could actually feel it is if you trap it between your hands. So they're showing you two different techniques where they're kind of pulling together on the top or they're pressing together here towards the midline. And that's really the only way. If you were to come laterally and push like this, you would not find it. So if you, and does this really change our treatment, our diagnosis, or an ultimate destination of a patient? No. I mean, I wouldn't spend a lot of time trying to palpate for it. If they have a good story, I would consider them abdominal aortic aneurysm until proven otherwise. But that's one of the things that is one of the diagnostic tests that's done. Okay. So again, a history taking of hypertension, the pulsation, palpating for the pulsating masses. Also, you can check blood pressures. If it's a thoracic one in the arms, if it's an abdominal one in the legs. So, if there's a difference in the pulse strengths and the blood pressures in extremities, that's also considered a possible sign of an aneurysm in the aorta and stuff like that. But they're all going to the hospital, right? We're not making them better in the house. So again, I wouldn't waste a lot of time doing that. There are ambulances that use ultrasound, just none in Rockland County yet, but in the emergency room, they will get ultrasound. That's the first quick way of trying to diagnose it. But at the best way or the golden standard would be like a CT angiogram. That would be the the golden standard of diagnosis and stuff like that. Now, what do they do for them? So the old way was open surgery, right? So in other words, here's a guy had a big belly, right? He's probably leaking some blood. They open him up and they find this huge aneurysm. Now you can make out a little bit of the aorta up here and maybe a little bit down here. The aorta is about the size of a half-inch garden hose. Okay, so this is much bigger than a 1/2-inch garden hose. So this is the area that developed the aneurysm. The old way was they would actually clamp, okay, get some good section of aorta, put a clamp on it, good section of aorta down here, distal to the aneurysm, put a clamp on it, cut it out, and sew in a new hose. That procedure was very, very, very dangerous, had a high death rate and stuff like that, resulted in kidneys shutting down, paralysis. There's a lot of side effects. Shutting blood flow through the aorta is basically shutting blood flow to the whole body. So they used to have to pack these people in ice, and time was monitored to the second. And they didn't do it in older patients who had comorbidities because the chances of them surviving were pretty minimal. So it was not a an ideal treatment, but it's what they basically had to be able to do. Nowadays, they do what they call endovascular treatment. So endovascular treatment is the new rage for pretty much everything. Heart attacks, we don't typically do bypass surgery anymore. They go in and through a blood vessel, reach up to the coronary arteries and stent over the blocked artery. Strokes, if it's a large vessel occlusion, they can pull out the clot, right? They go through the wrist and they bring a catheter all the way up to it. So that's all endovascular stuff. The same thing happened with the abdominal aortic aneurysm. So this is, I know it says pre-hospital management, but this is not the pre-hospital management, obviously. But what they basically do is cannulate the groin, the femoral artery in the groin. They bring a catheter up, okay, to beyond the aneurysm. And then they, on the outside of the catheter is this tube that can be deployed, made larger, okay, and the blood will now start going through the tube, putting no pressure on the aneurysm, so there's no risk of rupture. This is, a procedure that really, I don't want to say is risk-free, but the biggest risk of these types of procedures would be obviously maybe throwing a clot, but also bleeding from the site because you have an arterial venipuncture in the groin. So typically they have to lay flat for like 4 to 6 hours with a sandbag in place and stuff like that, just to keep their risk of bleeding down to a minimum. But these patients really probably, just like when somebody has a heart attack and they get stented through the groin, they probably within 6 to 8 hours are up walking around once they're sure there's no bleeding problems and stuff like that. The actual aneurysm itself will just collapse back down onto the graft, and there's no risk because the blood now is going through the graft, and there's no risk of that rupturing. So it's a pretty simple. I don't want to say simple. I mean, obviously these people who do it are very skilled, but it's a pretty straightforward procedure. Something vascular, I guess vascular surgeons do, interventional vascular surgeons and stuff like that probably are the ones who do it. And from what I understand, speaking to my wife, both Good Sam and Nyack can do these procedures. Now, whether they have the people there 24/7, that I don't know. But it's like anything in medicine, if you roll into the hospital during working hours, you're always going to have a better outcome than if you roll into the hospital, at 3 o'clock in the morning, just because of the staffing issues and stuff like that. So, again, for our standpoint, you need to go to the appropriate hospital. So since both hospitals in Rockland can do this, either one would be a fine choice. If for some reason, you call and they say, don't come here, probably your choices would be Westchester would be your next choice, or Hackensack. But, again, both hospitals in Rockland have this capability. It's just a question of, is somebody going to come in and want to do it, right? Oxygen definitely would be appropriate. It's not going to really change their outcome, obviously, but it's not going to hurt them. On an ALS level, fluids probably, if their blood pressure is really, really low, you might want to get their blood pressure up to 60 or 70 systolic, but you don't want to make it real high because you just run the risk of rupturing. Really, the pre-hospital treatment is to get them to the right hospital. There's nothing that we're going to do to make this, 100% better. Now, definitive care, again, the old way was to open them up and try to repair it that way. The new way is the endovascular repair, which has, much better outcomes, much older patients. My wife said she had a patient in her late 70s that this was done on. The next day, the guy came and visited her in the office. So it's like, it's definitely something that is, a safer procedure than the old way and stuff. Now, there's also the concept of watchful waiting. If somebody has a small aneurysm on CT scan and they're 70 years old, they may just tell them come back every year. And as long as it's not getting bigger, they may just leave them alone. There's nothing, so that's just kind of watchful waiting. My grandmother lived, 20 something years with an abdominal aortic aneurysm. Back then, there wasn't this procedure, so they didn't want to do surgery on her because she was older. But it was like watchful waiting. You know, she lived for 20 years, and she actually didn't even die from the aneurysm. You know, she died from a GI bleed. So, you know, it had nothing to do with the aneurysm. So, you know, there is that concept too of watchful waiting. But nowadays, because there's safer procedures done, that's probably not, you know, is done as often, because remember, you can't bill for watchful waiting. You can bill for a procedure like this, probably, you know, 100 grand. You can't, you know, bill for just telling the patient come back every year, you know, and we'll see how you're doing. So you see a lot of times that's a driving factor in, you know, in medical care. Okay, so any questions on the abdominal aortic aneurysm? Anybody ever have a patient with one? So, you know, like I said, not as common, especially now with most patients, their blood pressure is being managed and stuff, not as common. Okay, esophageal varices. So before we were talking about problems in arteries, now we're going to talk about problems in veins. So you know of 3 problems with veins. You know, you're going to learn about esophageal varices, you know about hemorrhoids, and you know about varicose veins. So veins are single-walled blood vessels that should not be exposed to high pressures. When they are exposed to high pressures, they weaken, right? And they bulge. So you've seen varicose veins on people's legs. That is a problem with, you know, that the blood pressure in the veins in somebody's legs got too high. Typically, it's caused by people who stand on their feet all day long without wearing pressure stockings, like people who are in the food industry and stuff like that. Or people standing at machinery all day long, you know, raises their risk. And pregnant woman is also a risk for varicose veins because it's harder for the blood to get from the legs back up to the chest because of the baby being in the abdominal cavity and putting pressure on the blood vessels. So it doesn't take, you know, that many weeks of being exposed at higher pressure for those veins to weaken and be permanently, you know, dilated. In hemorrhoids, it's because of straining when you go to the bathroom and increasing the pressure, right? And that's what happens there. With varicose vein, with esophageal varices, the problem is that typically it's a problem with the liver, because the same veins that connect into the esophagus are coming from the portal circulation in the liver. So people have hepatitis, people that are chronic alcoholics and get cirrhotic livers, get hardened livers, tend to get esophageal varices. And what happens is that the veins that line the inside of the esophagus become big and floppy and are at risk for bleeding. Okay. And when they do bleed, they're on the inside of the esophagus, so there's no way to control the bleeding, and the patients start vomiting up projectile amounts of blood, and it's you know, can be a fatal event. So there's nothing we could do to control the bleeding. All we can do is get them to the hospital. Ideally, what they do nowadays is they actually, I'll show you, they ban the varices before they ever start bleeding so that they can't run into this problem and stuff. So this is an endoscopy picture looking down the esophagus. The esophagus is a flat tube. It's not an open tube. So when food goes into your esophagus, the nerves in the lining of the esophagus sense the food, and they actually start squeezing and moving the food down the esophagus into the stomach, and that's called peristalsis. So to be able to do a picture like this down there, they actually have to put carbon dioxide in the esophagus to expand it. So if you ever had like a colonoscopy or an endoscopy or anything like that, you know, when you're done with it, you know, one of the big side effects, or not side effects, but one of the things that you're going to have for an hour or two is that, you know, if you had an endoscopy, you're going to be burping. If you had a colonoscopy, you're going to be farting until you get all that, you know, CO2 out of your system. Okay. So this down here, looking straight down here, is a vein that's bulging, right? So this one's not bleeding. This, you don't see any speckles of blood or anything like that, but this is a varice in the esophagus that could actually turn into a problem. Now, when they turn into a problem, what they actually do is they get almost a balloon-like protrusion that comes out of them. So this is the same esophagus, and you know, pretty much what 70% of it now is covered by this varice that, you know, came off of a weakened vein like this. Now, if you notice down along here, I was saying they band it. What they do is, if they can get to it before it starts bleeding, and this one looks like there may have been some bleeding starting to develop already, what they can do is they could put a rubber band on it, and I'll show you how they do it, which actually acts as a tourniquet and stops blood flow. Because remember, this is full of blood, right? This is a vein that's, you know, basically flowing up into this varice, like kind of like a mushroom. And this could rupture at any point and cause massive bleeding to occur in the esophagus. So you're going to have bleeding problems, you're going to have vomiting problems, you're going to have aspiration problems into the lungs, you know, if this happens. That's why it's not usually a very good outcome of these patients, you know, when they do that. But they have this device, okay, which is basically a tube, like an endoscopy tube that goes down, patient swallows into their esophagus. It has a camera, it has lights, it has, suction, and it's got these bands on it. And what they do is they go down into the esophagus and look for the varices. They put the device over the varice, they press a button on it and deploys a rubber band around the neck of the varice off the vein, and it acts kind of as a tourniquet. And over a period of a couple of days, it gets tighter and tighter and tighter and shrinks the varice where, basically it scars off and there's no risk of bleeding. And I don't know if the band actually dissolves or if you just pass it down into your stomach and go to the bathroom and expel it. I don't know exactly what happens, but at some point it may even just grow into the esophagus, may be absorbed into the tissue of the esophagus. I'm not sure what actually happens to it, but that's how they kind of deal with the varice. But again, this procedure works well when they're not bleeding. If this esophagus was full of blood, it would be very hard for them to navigate to the different varices and actually band them. So this is not something that if we brought a patient in with an active esophageal bleeding, they'd probably be able to do very, very effectively. But it does work well, before they have bleeding. So if patients call you, with a history of alcoholism or a history of hepatitis B and start saying, I'm tired all the time, I have no appetite, jaundice again is the yellowish discolorization you typically see in the white of the eyes or on the skin of people who have hepatitis or liver disease. Or they start saying they have discomfort in their throat, it's difficult for them to swallow. Or, again, if they're vomiting up blood, it may be too late, but it may be just only one that's starting to bleed and it's not too severe. Remember, any blood that makes it down into the stomach is going to cause almost instantaneous vomiting. If it's fresh blood, like from a varice, it's going to be bright red. If it's old blood, like from a GI bleed, okay, that's going to be like coffee ground type of a blackish coffee ground type of texture. So bright red bleeding is typically fresh bleeding, right, from the esophagus or from the stomach. So maybe that may be enough to, get them into the hospital before they have severe bleeding and they could get them banded. But when the bleeding does occur, it's like a horror movie. I only saw it once. It's like a horror movie. There's just gallons of blood coming out of these people going everywhere. There's just nothing to do. When they vomit, it comes out like the Exorcist kind of movie. So it's just, and the situation I saw, the patient didn't even survive to leave the emergency room. They were probably in cardiac arrest when they were brought into the emergency room. So, it's not usually a good outcome when they have severe bleeding. So there's not much that we could really do for them except get them to the hospital. Everything else, anything that's going to delay transport, would be detrimental to the patient. So, yes, we want to estimate blood loss. Yes, we want to get vital signs, but I wouldn't really waste time in the house doing it. What's important is to call the hospital and see if this is something they could actually handle, right? So like if you call Nyack and say, no, don't bring it here, go to Westchester, it would serve no purpose cruising into Nyack just to have them say, take them out or they really technically can't tell you to leave. They would have to actually take the patient and then call for another ambulance to transport them out. But all you're doing is wasting, care in these patients. So, or time in these patients. So it would be better just to, if they say they can't handle it, just to take the trip over to Westchester and stuff like that. Oxygen obviously is not going to hurt them. It's really not going to help them a whole lot because it's a bleeding problem. But the more oxygen we can get into their bloodstream, probably the better off they'll be. Just before I get, in case I forget, I think I mentioned it last month, but Nyack has become a primary angioplasty center for heart attacks. So if you have an ST elevation MI, you can go either now to Good Sam or Nyack. They have the same level of initial care for the heart attack patients. They've done a few cases, pretty good outcomes. We brought one in the other day out of City MD. Guy was driving from Long Island to his daughter's house in Rockland, had chest pain pretty much while he was stuck on the LIE and kept on coming. And called the daughter and said, I think I'm having a heart attack. She told him to go to City MD. I don't know why. They diagnosed him as a heart attack. They called for the ambulance to take him over to Nyack. The medics said that they sent the 12 lead in showing the MI, that when they pulled up in front, not only was the emergency department outside waiting for him, but the actual interventional cardiologist and the whole team was waiting, and they whisked the guy right from the ambulance straight up to the cath lab, and he had a pretty good outcome. He had a 90% occlusion of his inferior blood vessels going to the inferior wall and something like a 60% of his interior wall. So he actually had a good outcome and, did pretty well, was discharged from the hospital a couple of days later. So they seem like, they have their, they have their act together. So for a heart attack, either hospital now would be appropriate. And it's good also to have two options because, let's say there's 2 heart attack patients at NIAC. Well, they can only handle 2 at a time. So you'd have to go to Good Sam for the other one. And the same thing if Good Sam was full, now we have options of where to go outside of leaving the county and going to Valley or Hackensack or Westchester or something like that. Okay, and then the last thing we'll talk about tonight is appendicitis. So I think, everybody's had an appendicitis call or knows of a family member or a friend who's had an appendicitis. Your appendix is a little finger-like projection about the size of your pinky that's hanging off your large intestine. Okay, so your large intestine is when the food leaves your stomach, it goes into your small intestine. Your small intestine is small in diameter, but 20-something feet long. And then at the end of your small intestine, it goes into your large intestine, which is large in diameter, but only like a couple feet long. And then at the end of your large intestine is your rectum and your anus, and you go to the bathroom. So by the time the food gets to the bottom of the small intestine, it's pretty much gotten all the nutrients taken out of it. It's kind of like stool at this point. I mean, there's a little water and some nutrients coming out in the large intestine, but it's pretty much, stool at that point. So sometimes what happens is that a little bit of that, that digested food, used up food, gets stuck in the little pouch of the appendix. And it can cause, remember, your digestive tract is full of bacteria to help digest the food. So that bacteria can cause an infection to develop in the appendix, right? And, some people have appendicitis and, they're treated with antibiotics and they don't need surgery. That's not so common in America. They tend to do surgery, but it is possibly be treated with antibiotics if it hasn't perforated, it hasn't ruptured. The risk of appendicitis is if the appendix ruptures or perforates and spills the bacteria into the abdominal cavity, you're going to get what's called a peritonitis. The peritoneum is the lining of your abdominal cavity and the lining of your abdominal organs, and you can get an infection in that lining that could lead to sepsis and death. So that's why in America, they prefer just to take the appendix out. They used to say the appendix had no function, but they realize now that it does have some functions in your immune system. It assists with infections and also repopulates the gut with good bacteria. So it does have some functions, but you could live a fully normal life with having your appendix taken out. It's just like anything. If we were made with it, there's no real reason for it to come out, right? So unless you have a problem. I know somebody who's a paramedic and a nurse, didn't have health insurance, clearly diagnosed himself with appendicitis. He went to the hospital, had a CAT scan. They said it's not perforated. We're going to schedule you for surgery. He said, no, I just want antibiotics. And he did a 1 day in the hospital antibiotics IV and went home on 10 days of antibiotics, and he was fine. But he has a 25% chance of it reoccurring. So, but he said until he gets health insurance, he was, willing to take the risk. It's not something I would really advise most of us to do, but that's what he chose to do. A lot of times when people come into the hospital with appendicitis, they will give them antibiotics for 8, 10, 12 hours just to reduce the inflammation and swelling. It makes the surgery easier. Again, this is in a situation where it has not ruptured. If it's ruptured, they need immediate surgery because, every minute of that bacteria is floating around inside the abdominal cavity raises the risk of, massive infection and stuff like that. Now, in EMT class, you learned appendicitis had pain in the lower right quadrant. That's not untrue, but the earliest places when people first start with appendicitis is they get what's called periumbilical pain. So your umbilicus is your belly button. So periumbilical means pain around their belly button. Okay, so that's where it first starts. Once it gets more inflamed, it tends to localize to the lower right quadrant because that's where the appendix actually is. But the earliest presentations of appendicitis, just so we don't tell somebody, you just have a stomach ache, would be periumbilical pain accompanied with nausea, vomiting, diarrhea, constipation, fever, shakes, any of that would be all possible signs of appendicitis. Okay. Now, the reason why it would be important to kind of talk a patient into going to the hospital is that if they're going to have surgery, the earlier the surgery is done, the less complications. Like, in other words, somebody who has a non-perforated, non-inflamed appendix and a non-inflamed abdomen, they can do laparoscopic surgery, make 2 little incisions, on the wall of the abdomen or 3, depending on the situation, and go in and clip it out, right? They can go in with these camera operated little, arms, reach down to the appendix, clip it and pull it out with very minimal complications. When you have to have open surgery, the problem is they have to move your intestines, and there's always possibility that, you know, when everything's put back in, that it's not, the food's not going to go through it the right way, or you can have adhesions where the intestine gets stuck together, and then you end up with blockages and constipation and stuff like that. So, you know, if you're going to have a surgery, you know, for it, the earlier the surgery is done, the less risk there is of complications from the surgery. Okay. And then what I thought was interesting was that if the appendix actually ruptures, the pain goes away, because the pain is the swelling, the stretching of the appendix. So if it actually ruptures, the people tend to, you know, I don't want to say become pain-free, but definitely have a massive decrease in the pain. That may trick them into thinking, you know, everything's fine, but what's going to happen now is they're going to, you know, within an hour or two, they're going to develop, you know, that massive infection, and they're going to start with the fevers and the shivers and everything like that. And, you know, again, a peritonitis can be deadly, can kill people. So just if they say to you, oh, you know, I've been having this pain all day, but right before you came, it went away, it doesn't necessarily mean that they're out of the woods, right? It could just be that it ruptured and they have not yet developed an infection to give you any other signs and symptoms. Now, what can we do for these patients? Not much, right? This is a surgical fix. Again, you can put them on oxygen. It's not going to hurt them. I mean, if their pulse ox is above 94%, they probably don't need oxygen anyway. But, you know, if you want to feel like you're doing something, you put them on oxygen. But really, it's, you know, it's a quick transport, quick, safe transport to the hospital is, you know, is really what to do. You know, sometimes on ALS level, we may give them pain medications. We may give them medications to stop them with the feeling of vomiting and stuff, just to make them more comfortable. You know, again, most of us can use a little fluid. We all tend to be a little dry because we don't drink enough day, but none of this is really going to change the ultimate outcome, which is that they need to, you know, have their appendix taken out if it's got fecal matter stuck in it. That's kind of the standard of care in America. You know, I mean, most people are not going to try the antibiotic route, you know, or most hospitals would not even suggest it as an option. Say, okay, let's try, give you 2 days of IV antibiotics and send you home with 10 days and see how you do. They're just not going to offer that as even an option. They're just going to talk about surgery for it. Okay, so any questions on anything that we went over tonight? So if you give me one more second, let's just look at the quiz so you're not killing yourselves tonight trying to get through it. So we'll go through it and just make sure I covered everything. Okay, so it says, which of the following are possible risks associated with esophageal varices? So is hemorrhage a risk? I think we would all say yes, right? If they vomit, then aspiration is a risk, and hypoperfusion means low blood pressure. So if they have severe hemorrhage, hyperperfusion would be a risk, okay? So that would be kind of all of the above. Just remember the test is going to be scrambled, so they may not be in the same order. So don't just write one as D or anything like that, because they're not going to probably be in the same order. Possible signs and symptoms of an abdominal aortic aneurysm, okay? So bloody stools, not really, right? That's more like hemorrhoids and stuff like that. Sudden intense persistent abdominal or lower back pain, probably. Trouble swallowing, that's more like the esophageal varices. So out of this one, it's going to probably be B, right, is the most common sign that you would see. Okay, signs and symptoms acute, with acute appendicitis. So right lower quadrant pain, obviously you learned that as yes. Periumbilical pain tonight you learned as yes. And nausea, vomiting, and stuff like that also. So this would also be one where it's kind of all of the above. You're treating a 62-year-old male patient with a history of hypertension who's complaining of lower back pain, cold and numb left leg, and nausea, which are the following possible side effects. So again, you know, hypertension, lower back pain, numb leg. Out of what we talked about tonight, probably the most common thing that would be abdominal aortic aneurysm, where they threw a clot, right? So that's kind of what that one would sound like on presentation. New York State BLS protocol asks, administer which of the following medications on standing order for symptomatic asthmatic. So standing order, the only drug you can give is albuterol, right? You can't give epinephrine on standing order. It's a medical control option, and obviously nitroglycerin has no role in the treatment of a, you know, asthma patient. Okay, that would be more of an angina patient. Which of the following are possible signs of an asthmatic attack? So we said there is cough variant asthma, so that is a possibility. There is wheezing. So at this point, since A and B are correct, it's got to also be chest tightness. So it's all of the above, or all possible signs of an asthma attack in a patient. We're treating a 16-year-old female patient with a history of asthma, called stating that she's been having respiratory distress similar to her asthma symptoms for 3 hours. She has used her albuterol meter dose inhaler, that's her puffer, multiple times with no relief. She states the meter dose inhaler is a few years old, so we don't even know if it's still good. Your physical exam reveals a well-nourished 16-year-old female patient weighing approximately 110 pounds. She's in moderate respiratory distress. She's exhibiting some accessory muscle use. Her lung sounds are wheezes bilaterally on expiration, which is the common thing that you will have. Skin is warm, dry, and pink. No cyanosis is noted. She's got a pulse ox of 92% on room air, respirations of 28 in labored, a pulse of 110 in regular, blood pressure 110/70. So vital signs are not really super, remarkable. I mean, her breathing was a little fast and labored, but not terrible, right? Which of the following treatments would be most appropriate for this patient? So the question comes in, does this patient need epinephrine or not? The answer is no. She's conscious, she's alert, she's talking to you, she's moving air, her pulse ox is still 92%, so it's not terrible on room air and stuff like that. So she doesn't need epinephrine, she needs albuterol, okay? So the albuterol, we said, as far as the preferred way of giving it, would be the 2.5 milligrams and 3 mLs in a nebulizer at 6 liters. 12 liters would be too fast, you would use it up way too fast. So in that case, I would go with B. You respond to the home of a 48-year-old female patient. For a patient having trouble breathing, upon your arrival, we find the patient is supine in bed, unresponsive to verbal stimuli, with poor respiratory effort. So she's not doing too well. Family states the patient has been having trouble breathing times 8 hours and refused to go to the hospital. Patient last seen conscious 15 minutes ago. Patient had a history of severe asthma. Family states she almost died 3 times from asthma and has been intubated multiple times. So she's an asthmatic that has not been doing well. Physical exams, skin cool, pale, and diaphoretic. Cyanosis loaded at the lips. Lung sounds are very diminished. Okay, with wheezes, they're very diminished because she's very tight. She's not moving any air. And barely any respiratory effort is noted. So she is in that respiratory muscle fatigue, right? She's that status asthmatic, is dying patient. Vital signs, pulse ox 89% of room air. Pulse is slowing down, which is not a good sign, right? Because she's getting hypoxic, so her heart can't beat fast. 52 and irregular, respirations of 8 and shallow. Blood pressure 90/60. So this lady is crashing on us. So it says, which of the following are appropriate treatments for this patient? So number 1, initiate a bag valve mask at 16 breaths per minute would be definitely appropriate, right? She's not breathing well on her own. She's only breathing 8 times a minute. And then can we give her albuterol by a CPAP? So if she's not awake, CPAP doesn't work, right? So she's unresponsive to verbal stimuli, poor respiratory effort. It's too late for CPAP and albuterol. So now we have to go with epinephrine. So she is 48 years old. So we're going to assume that she weighs over 66 pounds. And we would go with the adult dose, which would be to 0.3 milligrams. Okay, so hopefully, oh, there is. Okay, so this one would be 1 and 3. So it'd be A if it comes out the same way on your test. Okay, and then status asthmaticus or severe asthma exacerbation. Exacerbation means like worsening. Is a condition where an asthma patient experiencing a severe asthma attack fails to respond to bronchodilator treatment. This condition can rapidly lead to respiratory failure and death, and that is true, right? We talked about that as the dying asthmatic, and that's where we would consider bag valve mask and the calling medical control for permission to use the Epipen. How can an EMT prevent the development of mucus plugging in an asthmatic patient? And that would be give them humidified oxygen. So that's going to be C. And then the last one, or the last 2, common side effects of albuterol administration is a sense of nervousness, tremors, and tachycardia. That is true. Okay, if you've if you've never used albuterol and the first time you use it, it will definitely make you feel all that. Okay, the more you use it, the less you'll get that. But sporadic use or one-time use and stuff, you'll definitely feel all that. And then according to New York State BLS protocols, how many total doses of albuterol may an EMT administer to a patient who's having difficulty breathing and who's wheezing on standing orders? So you can give up to 3 doses on standing order, 5 minutes apart. And then if you need to give additional, which again probably won't happen in Piermont, but if you need to do additional, then you would have to call medical control. But remember, the Epipen would always be a medical control option, never a standing order. Okay, so any questions on anything we went over tonight? Okay, so everybody have a good night. Have a good rest of the week, a good weekend. I'm going to send out the quiz right now. Okay, and if If for some reason you don't get it, then either text me or maybe Donna could forward it to you. You could text her or something like that. Okay.
Thanks, Frank.
No
Thank
problem.
you, Frank.
Everybody have a good weekend, and I'm
You
going to
too.
send it out in 1
Frank.
minute. And if anybody,
Thanks,
I'm recording it, so I'm going to put it up on YouTube. So if anybody who's not here tonight needs it, it'll be up on YouTube. They can just, text me and I'll send them the link and everything like that. Okay.
All right, thank you.
Thanks.
Okay. I think Candy was looking for that, and somebody else. I
Wait,
forgot.
hold.
So
Oh,
Can
can
you
you,
send it to
John
Amy?
Chadwick wants it.
okay.
Yeah, and I would send it to Amy too, because she went on the ambulance call.
Okay. So what I'll do is then tomorrow after it's posted up on YouTube, I'll just send an email to everyone saying, here's the link to it if you missed it.
Perfect.
Okay.
Thank you very
Thanks,
much.
Frank.
Good night.
You're welcome. Have a good night.